Good afternoon, everybody. I hope you can hear me and see me. So today we'll start with intestinal tuberculosis. I can do here. Please. Yes. Okay. As you know, TB is a very common disease. Okay, in India also and other developing countries. Okay, and a lot of complications, both medical and surgical, we come across. Okay, so I will basically confine to the surgical complications. So these are the various extrapulmonary manifestations of tuberculosis that you can come across. Okay, other than intestine or the peritoneal cavity, you can get in the brain, in the bones, joints, even the genitourinary system, etc. So, government of India declared this TB as a notifiable disease in the year 2012. So, in the intestinal TB, the area that is most commonly affected is the ileocecal region. Okay, and it can be again of the ulcerative type or the hyperplastic type, or the mixed component can be there, or only the ileum can be involved. Okay, and on the other component, it is the peritoneal tuberculosis per se, which will involve the peritoneum and can be manifested as an ascitic component or encysted type or the plastic type, where we call the cocoon, or the purulent ascites may be there. The third type can be the involvement of the mesenteric lymph nodes. So that it can present as a calcified lesion, or we call it sometimes as a painful lymphadenitis, or sometimes pseudomesenteric cyst. Okay. And besides that, it can even involve the anorectal region, the sigmoid colon, then also other solid organs like liver, your kidney or spleen. Okay, and rarely tuberculosis can also involve the esophageal or the gastroduodenal areas, which are very, very rare. So what is the mode of spread of the TB to the intestine? It can be by the form of egestion, when you ingest a food containing contaminated tubercle bacilli. Okay, then that may lead to we call it primary intestinal tuberculosis, when the person that was not exposed to the these bacilli earlier. Okay, or secondarily it can be if the person ingest sputum containing those tubercle bacilli. It can also be in the form of hematogenous spread from the lungs or through the lymphatics, and retrograde spread through the fallopian tubes. So as you know, other than Mycobacterium tuberculosis, there are other many varieties of this mycobacterium, like those bovis, africanum, microti, so many other types. They can also cause various types of disease. This you have already read in the microbiology, what is the appearance of this Mycobacterium bacilli. So this in the ileocecal TB, why this region is most commonly affected? Because as you know that there is a valve, there is the ileocecal valve, so that leads to some stasis of the any content that passes to the ileum, and it goes to the cecum little bit slowly. So maybe because of stasis, and there are abundance of these pairs patches full of these lymphoid follicles. Okay, so those bacilli might be trapped there, and then at a later date they may flare up. So these are the various hypotheses which might lead to increased incidence of this tuberculosis in the ileocecal region. Then there's the ulcerative type. This is usually secondary to pulmonary tuberculosis. The organism is more virulent, and the person also has less resistance. So it is also seen mostly in the ileum. The ulcers usually will be transverse in direction. there can be sometimes longitudinal ulcers, okay, which is more commonly seen in the ileum, but most common type of ulcer that you come across in tuberculosis is usually of the transverse type. These longitudinal ulcers, which you sometimes see in the ileum, that we see in the ring of in the form of napkin ring strictures. Then sometimes there can be even perforation and obstruction. Okay. So if you see here, you see that the ulcers are transversely placed mostly, but on the right side picture, you have seen this. There are longitudinal ulcers, which are known as napkin ring strictures. The other variety can be the hyperplastic type. This is especially the primary GI tuberculosis, where the organism is less virulent and the person has good resistance or good immunity, so that it can the body's immune system can fight against the bacilli. So because of this, there's hyperplastic reaction, and usually a mass will form in the right iliac fossa. And in this type of lesions, this cacheation, which is found very commonly in the tuberculosis, is usually rare. So this is some of the pictures how it looks when it is the hyperplastic type. So sometimes the patients may most commonly they present with pain abdomen, and pain abdomen not necessarily will mean perforation. Pain abdomen can be of colicky type if it is because of intestinal tuberculosis, or dull aching type in mesenteric limb adenitis. It will be just like any other features of obstruction. So we have to have the suspicion, especially in those endemic areas. And when you palpate, sometimes you may be able to feel a mass, and that mass will again mimic any other disease like carcinoma of the cecum, or even sometimes hemangioma or mycetoma. So, and sometimes this tuberculosis also can be associated with adenocarcinoma of the cecum. So we have to be careful. So the various differential diagnoses that will come across. So whatever you can think of in a right iliac fossa, like carcinoma cecum, hemangioma, or appendicular mass, sometimes lymph node mass, Schwarz abscess, or complications of Crohn's disease, or even sometimes if a person has undergone kidney transplant, then the kidney might be felt in the right iliac fossa, or also Schwarz abscess, which is not very uncommon. So the investigations that we'll try to do, basically if you have suspicion of tuberculosis, will be all the basic investigations, and ESR might sometimes be raised, but as you know, in any chronic disease, ESR will be raised. So if the patient comes to us with pain abdomen and you're suspecting either obstruction or perforation, then plain X-ray abdomen, both in the erect and the supine position, may be helpful. This erect position, you try to see the air fluid levels. As you know, up to 2 to 3 air fluid levels, it's taken as normal. When it is more than that, then it is considered to have some amount of intestinal obstruction. And in the supine position, if you take the plain X-ray abdomen, then you'll be able to appreciate which part of the intestine is obstructed. As you know, if it is jejunum, then we can see the valvulae conniventes. If it is ileum, we call it characterless. There's no markings. Or if it is in the large bowel, then those frustrations you might be able to appreciate. And as I have told already, that it is the ileocecal region that is most commonly affected. So usually either the distal jejunum or the proximal ileum you'll be able to appreciate. But for the appreciation of the contour of the intestine, usually you have to take the X-ray, plain X-ray in the supine position. That's why sometimes in exams you'll be asked why this supine position is important. In the erect position, you can tell there's some obstruction, but exactly you'll not be able to tell which part of the intestine is obstructed. But when you take the X-ray in the supine position, then you may sometimes be able to tell which part of the intestine is obstructed. So accordingly, you can plan your surgery. So as you can see, this is this X-ray which was taken in the supine position. So if you can see some amount of this, we call it valvulae conniventis, this jejunum, which is grossly dilated. Here, if you can see, these are the valvulae conniventis, okay, which are grossly. This is more or less circumferentially placed. So if it is ostration, then they'll not be covering the whole circumference of the bowel lumen, and you'll be able to appreciate the proximal part also. So in the ultrasound, you may be able to appreciate the thickened bowel wall, or there can be some collection, especially ascites, and then the mesentery also may be thickened, or the lymph node may be enlarged, and you can even go for FNAC from those enlarged nodes. And the cecum usually is pulled out because of fibrosis, which sometimes may be felt as a kidney. Okay, so that's why it's known as pseudokidney sign. Barium study usually is not advised, because barium, as you know, it cannot be absorbed. So if there is some obstruction, then that barium will be difficult to be retrieved, and it may lead to more obstruction. Means a partial obstruction may be converted to a complete obstruction. But if you do a barium enema, then this problem doesn't arise. Okay, but otherwise barium will follow through, will give you sufficient information. But only problem is this conversion of this subacute obstruction to a complete intestinal obstruction. Then these are the various signs that you normally come across. We call it starting sign, when the barium actually flows very rapidly from the ileum to the ascending colon. So as a result of which, you may not be able to appreciate the sickle shadow. Or the Fleischner sign, otherwise known as the inverted umbrella sign, where a narrow ileum with thickened ileocecal valve may be appreciated, or the napkin lesions, the one that I have shown before, or sometimes there can be multiple segmentations, we call it chicken intestine, or there will be gross dilatation of the proximal ileum. So you can see here, it is quite thickened, and then this ileum is very much thinned out. So these are some of the barium pictures which you can appreciate. Here the ileum is grossly distended because of obstruction. You can sometimes go for colonoscopy. Colonoscopy is basically to rule out other pathologies like carcinoma or any other problems. Then CT scan will show you the dilated bowels and also the mesenteric lymph nodes, which you can see here is quite enlarged, and then the thickened bowel walls. Sometimes we can go for diagnostic laparoscopy, where you can see multiple nodules that is studied all in the peritoneal cavity and also in the bowel serosa. Then here you can take biopsy and confirm the diagnosis and start the treatment accordingly. You can sometimes go for ascitic fluid tapping. That will be supplementary to your diagnosis. Usually for TB per se, operation is not done. But when there are complications, then only the role of surgeon comes. Complications can be in the form of obstruction, which will present with colicky pain, or sometimes with malabsorption. But for these, you do not really need surgery always. Most of the obstructions, if it is properly managed conservatively with the anti-tubercular drugs at a later time, then usually the patients will usually improve. If there is cold abscess, usually the abscess is not drained, and if you drain also, you have to drain always from a non-dependent area. Sometimes there can be hemorrhage, there can be perforation, or even fecal fistula due to spontaneous perforation from some obstructions. First line of treatment of any TB, irrespective of the anatomical location, it will be always medical management. Okay, there are, as you are aware, there are first line drugs and second line drugs. Okay, so depending upon the disease condition, you will decide which treatment to use. Usually, in the presence of intestinal obstruction, anti-tubercular drugs may not be suitable to be prescribed. In that case, usually this injection streptomycin may be started, and then after you relieve the obstruction, and when the patient is able to take orally, that is the time when you start your the other medications. The surgical management, basically, as I have said, supposing an obstruction has developed, intestinal obstruction, which is not relieved, okay, then there is severe hemorrhage or bleeding and perforation, or sometimes even intra-abdominal abscess or fistula formation may be there, or sometimes when the diagnosis is uncertain, as I have said, like there's a lump in the right lung fossa, and you are not very sure whether it is because of tuberculosis or there's some growth in the cecum. Okay, in that case, maybe you are justified to do for surgery. And in the surgical management, usually if it is non-malignant, as I have said, then what you do is we try to resect minimum. Okay, even though you may sometimes have to do this right hemicolectomy with hilus transverse anastomosis, but in the case of malignancy, the surgery that you do, that's right hemicolectomy, it has to be a little bit more extensive, including more of mesentery. But in cases of ileocecal tuberculosis, usually we'll try to do conservative with less margin from your mesentery side. Or if there is a single stricture that is causing the obstruction, then you just go for strictureplasty, or you can even go for resection. And if there are multiple strictures, then you usually go for resection and anastomosis. Then if there's perforation, then you may resect, or you may have to anastomose also, or if the bowel is too friable, then usually the proximal end of the resected bowel is taken out as a stoma in the form of ileostomy, and when the patient recovers, then after giving anti-tubercular treatment, then you go in for closure of the stoma. Then you can go for adhesiolysis if you find that only adhesions are causing the obstruction, but usually difficult because there will be a lot of the tissues will be very friable and there will be a lot of bleeding. And if there is some abscess, then you can drain the abscess, or if there is fistula which is already formed, then maybe you can again do some stoma. So these are just the presentations, how they might present. If it's ileal tuberculosis, usually it can be in the form of stricture or perforation. So depending upon the presentations, the management of what I have told just some time back, that management you will decide depending upon the presentations. But the primary line of management is anti-tubercular treatment, and only when the complications are there, that is how we try to manage surgically. Like you can see here, this is a case of peritoneal tuberculosis. So these type of patients can be basically managed with medications. Here also you can see, we call it abdominal cocoon. The various parts of the peritoneum, they get inflamed and they get adhered to each other including the omentum. So the whole of those small intestines may be wrapped with a layer of omentum, okay, in the form of a cocoon, and which is very, very difficult to sometimes even go in. Okay, because while you are trying to find the intestines, you may even perforate, and sometimes even you may have to abandon. Then, if it is because of it will present like any other case of acute abdomen. So when you see that there is no perforation, obstruction is there, then that's it, you relieve obstruction. If there's perforation, if the tissues are okay, then you can go in for primary repair. But most of the time, tissue is very fragile. And as a general condition, the patient also a little bit frail, then it is better to perform some stoma, okay, ileostomy preferably, and then build up the patient nutritionally, start the antitubercular treatment, and then at a later date, you close the stoma. And remember, whenever you are closing the abdominal cavity or the peritoneal cavity in an operation case because of TB, then usually we do not try to put drains. Otherwise, it may be difficult to decide when to remove the drain because lot of ascitic fluid will keep on draining, and then that will lead to hypoproteinemia and other electrolyte imbalance. In the chronic form also, the patient can present with pain. There can be loss of appetite, or sometimes we call it doggy abdomen, where there can be multiple intraperitoneal interloop adhesions between the bowels, okay, that may lead to the doggy sensation. Or otherwise, there can be ascitic form or encystate, or the plastic, there's a cocoon, or purulent form of tuberculosis. Then if it is because of the tuberculosis, if there is ascitic peritoneum, then usually if you are able to get some fluid, then you diagnose, then your treatment will be basically medical. So here the only difference is the medications may have to be given a little bit longer, for at least 1 year. And sometimes a repeated tapping, peritoneal tapping may be required. Others there will be abdominal discomfort, which may even compromise the respiration for the patient. Then the encysted, the loculated peritoneal tuberculosis, where the calations may be loculated, there the shifting dullness, if you find also, usually it will be non-shifting. Sorry, the ascitic fluid that you find, usually it will be non-shifting, unlike the pure ascitic type of peritoneal tuberculosis. Rather, it may sometimes mimic some other cyst like mesenteric cyst or ovarian cyst. Usually, once the diagnosis is confirmed, the treatment is antitubercular treatment. And the plastic or the cocoon, abdominal cocoon that I was telling, that is the one that sometimes may be difficult to manage. Okay, very gently you will try to release the intestines and then try to relieve the obstruction. This plastic type usually, plastic type of peritoneal tuberculosis usually will present like a intestinal obstruction. So once you release the obstruction, sometimes recurrence can be there, or if the person is okay, then you go for antitubercular treatment. Then if there's pus, then you usually try to give the antitubercular treatment, and then that may be sufficient. So if there's mesenteric lymphadenitis, this usually antitubercular drugs will be sufficient, because as you know, mesenteric lymphadenitis, even though some pain may be there, but usually will not lead to any complications. Mesenteric lymphadenitis are more acute mesenteric lymphadenitis. These are more common in children. Sometimes it will just mimic like acute appendicitis. But when you examine the patient in the left lateral position, because the mesentery will move in more medially when you turn the patient to a left lateral position, then in a case of acute mesenteric limb adenitis, the tenderness may be shifting. But whereas in the case of acute appendicitis, because of the inflammatory process that will lead to some amount of adhesion, the area of tenderness usually will not shift. Okay, that is how, to some extent, sometimes we may be able to differentiate between a case of acute mesenteric limb adenitis and acute appendicitis. Otherwise, the treatment is clear-cut anti-tubercular treatment. So, remember, the mainstay of treatment will always remain is a anti-tubercular treatment. The surgery, role of surgery comes only when there is complication. Sometimes there can be even fistula, perianal fistula can be there, or fistula from the bowel communicating with your other viscera, or with the enterocutaneous fistula can be there. So in that case also, the primary treatment will be, if the patient doesn't have any other features of peritonitis, then the primary treatment will be anti-tubercular treatment. Sometimes tuberculosis may only involve the omentum, and in that case, there will be omental caking, or the omentum may be rolled up towards the stomach. Okay, or even some loculated collations may be there within the omentum, and then leading to abscess. So the primary modality of treatment here also will be anti-tubercular treatment. Usually the patients will be young adults, and then constitutional symptoms which is not typical of this abdominal tuberculosis, which is found in any other tuberculosis, may be present. So in here the patient is having a lot of obstruction, mechanical obstruction, or maybe because of ascitic also, the abdomen may be distended. So next class we'll discuss about the inflammatory bowel disease. You read a little bit, then you'll have better understanding. This intestinal tuberculosis per se, you will not get as a case, but sometimes some questions may come in the long questions, or sometimes even the short notes. So you should read. Okay. So I think that's all for today. Okay. Now Dr. Arup will come after some time, then he'll be taking your next class. Okay. Thank you all.